Male factor infertility. In one third of all cases, the male is directly responsible. In one third, both partners are responsible. And in remaining third, the cause of failure is attributed entirely to the female. Faults in the male. Disorders of spermatogenesis in 50%, obstruction of the efferent ducts in 30%, disorders of sperm motility in 15%, sexual dysfunction unexplained in 15%. For adequate spermatogenesis, testicle must lie in its correct position in the scrotum, where the temperature is slightly cooler than elsewhere in the body. The factors which raise the scrotal temperature can adversely affect the spermatogenesis, like occupation of men who work as chalkers or in blast furnaces are subjected to excessive heat, the wearing of tight scrotal support, the presence of a varicocele. The ectopic or undescended testis provides best example of adverse effect of temperature on spermatogenesis. The vas deferens itself may be occluded. This is suspected if there is herniorrhaphy scar or doubted if the scar is bilateral. Chronic inflammatory disease of prostate, seminal vesicle may be associated with male infertility. Congenital lesions of the penile urethra, such as hypospadias, provides an obvious mechanical explanation for imperfect insemination. History of mumps, venereal disease, diabetes, thyroid, tuberculosis may suggest testicular atrophy and obstruction. The goal, the occupation of the male, history of excessive smoking. Indulging in excessive alcohol consumption, chewing tobacco, gutka may also suggest poor spermatogenesis. Accidental or operative trauma, blow on testicle with a hematoma formation and subsequent atrophy, or operation for hernia, varicocele, hydrocele may suggest a degenerative lesion of the testis or obstruction to the vas. About 1 to 2% males suffer from genetic defects like Klinefelter syndrome with a 47XXY chromosome. Etiological classification is divided into genetic causes, abnormal Y chromosome, XXY as in Klinefelter syndrome, disorders of spermatogenesis, hormonal or pretesticular causes like hypothalamic disorder, Kallmann syndrome, pituitary secretion of FSH-LH, hyperprolactinemia causing impotence or diminished libido, hypothyroidism, adrenal gland disorder and diabetes, primary testicular disorders or testicular causes like idiopathic, varicocele, absent germ cells, chromosomal defect, Klinefelter syndrome, cryptorchidism, drugs, radiation, calcium channel blocker, anticonvulsant, antihypertensive, spironolactone, cimetidine, orchitis, chronic illness, immunological disorders, immortality due to absence of dyne in arms, absent cilia is in Carter-Jenner syndrome, duct obstruction or post-testicular causes like congenital absence, inflammatory block, gonococcal or tubercular infection, surgical trauma, Young's syndrome, incipitated mucus associated with sinusitis and bronchiectasis, E. coli, Staphylococci, chlamydial infection, Mycoplasma genitalis causes DNA fragmentation of sperms, decreased motility and apoptosis, disorders of sperm and vesicular fluid, sperm antibodies, low fructose in the seminal plasma, immotile cilia syndrome or Carter-Jenner syndrome, sperm acrosome defect, zona pellucida binding defect, zona pellucida penetration defect, oocyte fusion defect, sexual dysfunctions like low coital frequency, impotence, hypospadias, premature ejaculation, retrograde ejaculation, psychological and environment factors such as smoking, alcohol, tobacco, diabetes, drugs, antihypertensive, antipsychotic, cimetidine, sex steroids, chemotherapy, nitrofurantoin, beta blockers, spironolactone, and estrogen. Obesity increases the peripheral conversion of androgen to estrogen and affects the fertility or any chronic illness. Investigation. History includes age of the male partner, previous marriage, duration of infertility, any contraception practiced, the coital frequency, the occupation, habit of smoking, alcohol, tobacco, history of tuberculosis, any STD, diabetes, chronic illness, any operation on the scrotum, undescended testes or hernia repair, any coital problems such as premature retrograde ejaculation, failure to ejaculate. General examination in a standing posture to look for the size of testis, presence of varicocele, thickening of the vas, and a perrectal examination for obvious prostate enlargement, tenderness in seminal vesicle. A normal report rules out any major general or local causes of male infertility. One can move on to further investigations. General height increased in Kallmann and Klinefelter syndrome is due to late closure of epiphyses of the bones. Weight, obesity may point out to hormonal defect. Secondary sexual characters are abnormal, as in Klinefelter syndrome. Gynecomastia associated with Turner-like stigmata. Local examination include examination of the penis, scrotum and look for any surgical scar. Normal testicular volume is 15 to 35 ml. Testicular volume of less than 6 ml is seen in atrophic testis and Klinefelter syndrome. Testis should be well placed in the scrotum. Epididymis should be palpated for enlargement and thickness. The vas feels thickened in inflammatory condition. Rectal examination includes prostate examination. Presence of varicocele may be demonstrated when the male is examined in standard post and on Doppler ultrasound. Special investigation includes semen analysis, hormonal assay, FNAC of the testis, testicular biopsy, immunological tests, patency of the vas, chromosomal study. Semen analysis. It is the most important part of male investigation. The best specimen is one obtained by masturbation in the vicinity of the laboratory because this guarantees its freshness. Avoid changes due to temperature variation. Coitus interrupted into wide neck bottle may be employed. Post-coital test described later. The best specimen will be produced if a short period of abstinence of 3 to 5 days is observed. A typical normal specimen should show the following features when examined within 2 hours of the production. The semen should coagulate soon after ejaculation due to the enzyme in the seminal vesicle, but liquefy in 30 minutes because of the prostatic enzyme. The semen is greyish white in color. 2010 World WHO Organization standard for analysis are volume 1.5 to 5 ml, pH greater than 7.2, viscosity less than 3, sperm concentration greater than 15 million, total sperm number greater than 39 million per ejaculate, 32% greater than 32% motility, greater than 2 forward progression, greater than 4% normal morphology, round cells less than 1 million per ml, sperm agglutination less than 2. Low volume may be due to the following: incomplete collection, poor abstinence, abnormalities in seminal vesicle, partial vas obstruction, retrograde ejaculation, and hypogonadism. Aspermia means there is no semen. Azoospermia means no sperm in the semen. Oligospermia is low sperm count. Asthenospermia is no motile sperm or diminished motility. Necrospermia means dead sperms. Tetrospermia means abnormal morphology of the sperms. Normal sperm is motile, 50 microns in length, half of the size of ovum, and consists of head covered by an acrosomal cap, neck, body, and tail. Hypospermia means low volume, less than 1.5 ml. This is due to improper collection or retrograde ejaculation. Hyperspermia with more than 5.5 ml means prolonged abstinence or inflammation of seminal vesicle. The most important factor is the density of the sperm, and count below 15 million per ml are usually associated with infertility. Oligospermia is mild and the count is 10 to 20 million, moderate when 15 to 5 million, severe when less than 5 million sperms are seen. If one report shows abnormal findings, patient should be instructed to produce another specimen after a month or so. During this time, patient should be advised to take a good nutritional diet, restrict smoking and consumption of alcohol. He should take cold or tepid bath and discard the tight underwear. After 2 negative or below average count, he should be proclaimed azoospermia or oligospermia. Chromosomal study should be done. Postcoital test, Sims or Hahner test, PCT. The couple is advised intercourse close to ovulation time, preferably in early hours of the morning. The woman presents herself at the clinic within 2 hours after the intercourse. The mucus is aspirated from the cervical canal, spread over the glass slide. Another spear made from the posterior pornix serves as the control. Normally, 10 to 50 motile sperm are seen as per high-power field in cervical mucus. If there are less than 10 sperms, proper semen analysis should be undertaken. The sperm should show progressive but not rotatory movement. The presence of antispermal antibody in the cervical mucus leads shaky rotatory movements to the sperm and or may totally immobilize them. The cervical mucus is simultaneously examined for its quality, viscosity, and Foehn test. The advantage of this test is that cervical mucus can simultaneously studied for estrogenic effect and ovulation. Its capability to allow the sperm penetration and the presence or absence of any anti-sperm antibody. The test is useless in the presence of cervical infection, which should be treated before performing the test. Immunological factor is encountered in 5% of the cases. This test is less employed lately. Many gynecologists consider this obsolete. A test called Miller-Korjok test consists of placing ovulation mucosa on a glass slide alongside the specimen of husband semen and studying the penetration of the sperms under a microscope. Normal cervical mucus permits invasion of the motile sperms. It is less than 3 cm at 30 minutes. Penetration less than 3 cm at 30 minutes is abnormal. Sperm penetration test. Physiological profile of the sperms can be studied in vitro by using the zone-free hamster egg, which resembles the human ovum. The normal sperm is capable of penetrating the zona-free hamster egg, showing its fertilizing capacity. It is expensive and not reliable. Semen cervical mucus contact test. Equal quantity of semen and mucus is mixed so that there is no interference. In the presence of antibodies, more than 25% sperms show jerky or shaky movement by 30 minutes. The cross-check with donor sperm will indicate the source of antibodies, whether it is cervical or seminal antibodies. Testicular biopsy is indicated in azoospermia to distinguish between the testicular failure and obstruction in the vas deferens. It also reveals whether the seminiferous tubules are normal but unstimulated by the anterior pituitary gland, or whether they are incapable of function due to primary gonadal failure. Testicular biopsy will establish which of the factor is at fault. The biopsy can also diagnose genital tuberculosis. The true-cut biopsy under local anesthesia is simple to perform. 1 to 3% of males have endocrine dysfunction. In recent time, testicular biopsy has a very big role to play. Apart from chromosomal and histological study, testicular tissue provides cryopreservation in assisted reproduction. FSH level. High FSH denotes primary gonadal failure. Normal level in azoospermia suggests obstructive lesion in the vas or epididymis. Low FSH indicate pituitary or hypothalamic failure and a need for FSH, LH, GnRH treatment. Prolactin level more than 30 nanogram per ml indicates hyperprolactinemia requiring treatment. Low testosterone level indicates low LH or Leydig cell dysfunction. No response to GnRH suggests pituitary failure. Chromosomal study. Karyotyping should be undertaken in azoospermic men. 15 to 20% of them have chromosomal disorder. Most common is 47XXY or Klinefelter. Immunological disorder. A recent interest in immunological aspect of infertility has led to the detection of various sperm antibodies, both in seminal plasma and in cervical mucus. Immunological factors may be important etiologically in up to 5% patients with male infertility. An immunological test is required in case of abnormal postcoital test, abnormal semen profile, unexplained infertility. Ultrasound scanning. The ultrasound scanning of the scrotal defect, scrotal volume, varicocele, and is useful in ultrasound guided biopsy. Vasogram. It is required when normal FSH level is associated with azoospermia.